Hematological malignancies or disorders, baby. These are the anemias. Let's get started. What about megaloblastic anemia? Well, you got a B12 and a folate deficiency, which leads to a decrease in DNA synthesis, which therefore leads to the RBCs that grow larger than normal before they start dividing. So let's go over a quick review of B12 and folate metabolism. Folate is absorbed where? In the jejunum. The enzyme intestinal conjugase is required for absorption. Let me ask you a question. What drug inhibits intestinal conjugase and can give you a folate deficiency? Phenytoin. Very good. Now, vitamin B12 is absorbed in the terminal or distal ileum. Vitamin B12 absorption is slightly more complicated. B12 is bound by R factor, which protects it from gastric acidity. Now, in the duodenum, pancreatic enzymes hydrolyze the R factor bound, and the B12 is bound by intrinsic factor, which is synthesized by who? That's right, the gastric parietal cells. Then the B12 intrinsic factor complex is absorbed in the terminal ileum. Now, folate and B12 are required for the synthesis of DTMP. Both folate and B12 are required for the synthesis of DMT. Now, B12 deficiency causes neurological symptoms. Neurological signs and symptoms. You get a loss of the dorsal column function, which leads to a decrease in vibration and position sense. You get a loss of the spinocerebellar tracts, which is going to lead to what? Decreased proprioception. Very good. And you get a demyelination of the lateral cortical spinal tract, which leads to spasticity and weakness. The neurological symptoms in B12 deficiency are due to the failure of methylmalonyl-CoA mutase to turn into succinyl-CoA. And the increased methylmalonyl-CoA causes an increase in propionyl-CoA, the precursor. And that causes replacement of acetyl-CoA with propionyl-CoA, which leads to demyelination. So that's why you get neurological symptoms. Now note, a megaloblastic anemia caused by a B12 deficiency can be corrected by administration of something, but the neurological effects will not go away. What do you think you could administer to get the megaloblastic anemia caused by B12 to go away? Folate. You can give a vitamin B12 deficient person folate, but the neurological symptoms will stay. Your lab values, you're going to see, let's get some of this off here. Your lab values, you are going to see hypersegmented neutrophils. Hypersegmented neutrophils, an increased serum homocysteine level, and an increased serum methylmalonic acid level. Now, the increased serum methylmalonic acid level you only see in B12 deficiency. So right here, definitely know that. That's how you can differentiate the two. So, moving right along, let's talk about pernicious anemia. This is autoimmune gastritis leading to decreased intrinsic factor. So you could also look at achondroplasia, which is antibodies against intrinsic factor, which is pathognomonic. So we got this thing called the Schilling's test. And part 1 is where the patient is given an oral dose of radio-labeled B12 followed by an intramuscular injection of non-radio-labeled B12. It's positive if less than 5% of the radio-labeled B12 is detected in urine after 24 hours. If less than 5% is detected within the urine in 24 hours, it indicates pernicious anemia or what else? Malabsorption. Now the Schilling's test part 2, you perform if part 1 is positive, you give oral intrinsic factor. So part 2 of the Schilling's test, you give oral intrinsic factor plus labeled B12, followed by an intramuscular injection of non-labeled B12. If the urine B12 level increases, then it's pernicious anemia. If the urine B12 doesn't increase, it's malabsorption, like Crohn's disease or maybe Diphyllobothrium latum, the fish tapeworm, etc. But it's malabsorption of some kind if the urine B12 does not increase. That's after the part 2, where they've already tested positive for less than 5% of the radio-labeled B12. Now we're going to give them oral intrinsic factor, labeled B12, followed by intramuscular injection of non-labeled B12. Okay? And if the urine B12 increases, it is pernicious anemia. So, what is the Schilling's test exactly? The Schilling's test is done when a GI cause for B12 deficiency is suspected. Under normal circumstances, radioactive B12 should be absorbed in the gut and excreted in the urine. When there is a defect in the absorption pathway, less B12 is seen in the urine. So that's what the Schilling's test is all about. At that point, the potential causes of B12 malabsorption can be individually ruled out. Some of the causes of B12 malabsorption include bacterial overgrowth, which leads to B12 breakdown, pancreatic insufficiency with decreased absorption, like we said, Diphyllobothrium latum, the fish tapeworm, or terminal ileal disease, where you have an inability to absorb B12, etc., etc., etc. So, what about a folate deficiency? Well, folate deficiency is similar to B12 deficiency in presentation, except there are no, what? You tell me. Neurological signs. There are no neurological symptoms. It's commonly seen in alcoholics, pregnant women, celiac SPU, giardias, phenytoin use, chemotherapy agents like methotrexate, TMP SMX. TMP is a dihydrofolate reductase inhibitor, just like methotrexate, so that's why that works. Valproic acid. A folate deficiency causes neural tube defects with valproic acid, and zibutidine or AZT. So that is a folate deficiency for you. And that pretty much covers megaloblastic anemias. So let's talk about anemia of chronic disease, or microcytic anemia, one of them. Now, anemia of chronic disease occurs in the setting of a chronic infectious or inflammatory process. It is one of the most common causes of anemia in hospitalized patients. So common causes include chronic infectious processes like TB, osteomyelitis, and lung abscesses. Also some malignancies like Hodgkin's lymphoma, lung or breast malignancies, and even autoimmune diseases like SLE, lupus, and RA, they can all cause anemia of chronic disease. So what's the pathophysiology behind anemia of chronic disease? It's related to the persistent release of inflammatory mediators. So if you get an inflammatory state, what happens is you get IL-6 production. Once you get an IL-6 production, it leads to a decreased release of iron from iron stores by upregulating synthesis of hepcidin. So when you upregulate hepcidin, you decrease the release of iron from iron stores, okay? Hepcidin is a hepatic protein which inhibits the transport of iron. It inhibits the transport of iron, okay? And it inhibits the transport of iron from the bone marrow macrophages to developing RBC. So that's why we see this anemia. Thus, the RBC production takes place in a state of perceived iron deficiency, despite the fact that iron stores are in fact adequate. So the laboratory examination is crucial for differentiating anemia of chronic disease from iron deficiency anemia. Because iron stores are normal or even elevated, ferritin is increased. So yes, ferritin is increased. However, circulating iron in the blood is low, so you get a decreased percent saturation of transferrin in serum iron. Like you see right here, decreased percent saturation of transferrin in serum iron, plus a low TIBC, which is what is carried by iron. And this is wrong. It should be a decreased MCV. So let's do a summary of labs of anemia of chronic disease with iron deficiency anemia so you can see that. Alright, so if we have an iron deficiency anemia, an anemia of chronic disease, iron deficiency anemia is going to have a decreased serum ferritin, whereas anemia of chronic disease is going to have an increased serum ferritin. They both have a low MCV. They both have a decreased saturation of iron. But now, which one has a high TIBC and which one has a low TIBC? Well, iron deficiency anemia has a high TIBC, and anemia of chronic disease has a low TIBC. So that's how it's the TIBC and the ferritin that separate iron deficiency anemia from anemia of chronic disease. Now, the treatment of the underlying inflammatory condition is paramount. You do not, I repeat, you do not give iron, okay? It's the treatment of the underlying inflammatory condition that is paramount. So that is anemia of chronic disease. So moving right along. So what about iron deficiency anemia with the microcytic? It's most commonly from chronic blood loss. Most chronically from chronic blood loss, so like menorrhagia, gastrointestinal bleeding, such as colonic polyps or cancer, maybe a Meckel's diverticulum in a child, etc. It can also occur in breastfed infants because human milk has low iron, so they can get iron deficient. Also note that iron is absorbed where? It's a special place, in the duodenum. So any disease process of the small intestine, like Crohn's would be a great example, that affects the duodenum may compromise iron absorption. So now we get this thing called Plummer-Vinson syndrome. Plummer-Vinson syndrome. He's a triad of anemia, glossitis, and esophageal webs. Be suspicious if a patient presents with symptoms of dysphagia and has concurrent anemia. Patients with Plummer-Vinson syndrome may have an increased risk of developing esophageal squamous cell carcinoma or squamous cell cancer. Now, the labs of iron deficiency anemia we've already talked about. Going to have a decreased serum ferritin, or serum iron, I'm sorry. You're going to have a decreased serum ferritin and a high TIBC. That's your clue right there, high TIBC with iron deficiency anemia. Now, iron deficiency anemia is treated by replenishing iron stores. So you give oral iron. Now, oral iron is the mainstay of therapy for iron deficiency anemia. Oral iron tablets should not be taken with tea, coffee, calcium supplements, as these will decrease the absorption. Conversely, vitamin C or orange juice will increase the absorption of iron. So is iron acidic or is it basic? You know it's acidic, right? So some side effects of oral iron include nausea, vomiting, and constipation. Additionally, iron tablets will cause the stool to appear black, but this is not because of GI bleeding. And we can also give it parentally, or we can give a blood transfusion for iron. And that is iron deficiency anemia for you. So now let's talk about the thalassemias. So what are thalassemias? Well, thalassemias are defects of globin production, either the alpha globin or beta globin. Chains get disrupted. So you can get mutations in promoters, introns, and exons can all cause this disease. It's mild disease can be due to splicing defects, but its severe disease can be due to mismatched mutations, which is going to lead to an absent what? An absent beta chain. So let's talk about beta thalassemia major right here. Now, beta thalassemia major's genotype is as follows. So now the beta naught means it's an absent beta hemoglobin synthesis, and the B plus or the beta plus means it's a reduced beta hemoglobin synthesis. So as you can see here, one is going to be totally absent, one is going to be halfway absent, and the other one is just going to be reduced. So that's beta thalassemia major's genotype. All right, it's a severe anemia requiring transfusions. You need alpha chains that form insoluble aggregates because of the decreased beta chain. The RBC lifespan is decreased. On the smear with beta thalassemia major, you will see microcytosis, hypochromasia, target cells, and polycytosis, cytosis. That is the smear you will see. Now, do you think you're going to see an increased erythropoiesis? Yes, you will, and that's going to lead to bone marrow expansion, and that's where you get this whole crew cut appearance on skull x-ray, and we'll take a look at that right there. And that's what they're talking about, is this crew cut appearance that you see right here. See how it's kind of got like a crew cut to it? That's seen in beta thalassemia major. So it's a skeletal distortion because of increased erythropoiesis. Now, they will have hemoglobin F, which is alpha 2, gamma 2, hemoglobin F, is present throughout their life. Their complication is iron overload that is most commonly due to frequent blood transfusions, but can also be due to increased iron absorption because of the anemia. So let's talk about beta thalassemia minor. So beta thalassemia minor has a genotype beta O, beta, or beta plus beta. So that's beta thalassemia major. So normal beta is just normal beta synthesis, and beta plus was the reduced, and the beta naught is the absent. So as you can see, you just got one guy here that's halfway absent, he's halfway normal. But this guy's a little bit reduced, but he's mostly normal. So that's beta thalassemia minor, and it usually presents as a hypochromic microcytic anemia. Target cells are often present. Don't forget that target cells. It's usually asymptomatic, and the presence of alpha 2, epsilon 2 differentiates this iron deficiency anemia with the hemoglobin A2 levels that have been empirically determined to be decreased in iron deficiency anemia. So what about alpha thalassemias? Well, we see these in Southeast Asia. There are 2 alpha globin genes, 2 on each of chromosome 16 for 4 alleles. Deletion of one allele leads to a silent carrier, so there's no clinical significance. But if you have a deletion of 2 alleles, the alpha thalassemia trait, which is a mild microcytic hypochromic anemia, it's clinically similar to what? Beta thalassemia minor. So it can have cis or trans deletions. So you can get deletions of 3 alpha alleles leading to hemoglobin H disease. Hemoglobin H disease. Chronic hemolytic anemia with episodes of severe anemia or pallor. You can have excess beta chains that aggregate, resulting in extravascular hemolysis. So that could be clinically similar to beta thalassemia minor. Now, if you have a deletion of all 4 alleles, that's called H. Bart or hemoglobin Bart's disease. Hemoglobin Bart's disease if you have a deletion of all 4 alleles. So this is when you get hydrops fetalis or intrauterine death. Note that hemoglobin Bart's is present whenever an alpha gene deletion occurs. So the best diagnostic test for thalassemia is hemoglobin electrophoresis. And you do not treat these patients with iron. No iron for thalassemia patients. All right, here's some examples of target cells. Right there, see how it looks like a target. And then we already talked about the crew cutter period. So let's talk about aplastic anemia. All right, so aplastic anemia. This is usually from a toxin exposure, which leads to a hypocellular bone marrow, as you can see in the picture. Hypocellular bone marrow leads to a pancytopenia. Pancytopenia, including reticulocytopenia, thrombocytopenia, and severe neutropenia. Now, exposure to radiation, benzene, chloramphenicol, gold salts, which is an old treatment for RA, these can all cause aplastic anemia. Also, the one that the USMLE loves to test you on is the parvovirus. Parvovirus B19 specifically. He can cause aplastic anemia in sickle cell patients who are at a higher risk than normal. So what does the labs look like? Well, you're going to see a reticulocytopenia, a normal mean corpuscular volume. In severe cases, you can see macrocytosis, which is a MCV greater than 100, but it may be seen. That's what you're going to see. You're going to see a normal MCV and a reticulocytopenia. Now, bone marrow suppression, bone marrow aspirations show hypocellularity. That's, like I said, hypocellular bone marrow. So that's what the bone aspiration is going to show. Now, if chronic and severe hemosiderosis, which is systemic iron deposition, can occur. Hemosiderosis, when you get iron stuck in your bone marrow, and as you can see with all these cells, that is definitely aplastic anemia if you ever see that. So, moving on, let's talk about normocytic anemias. So, enzyme deficiencies is up first. What enzyme deficiencies are we talking about? Well, there is two that come to mind, and that is G6PD and pyruvate kinase deficiency. So G6PD. So what do we know about it? He is caused by a decrease in what? That's right, a decrease in NADPH. NADPH formation through the hexomonophosphate shunt, or the HMP shunt. Now, NADPH is responsible for regenerating the reduced form of glutathione from its oxidized form. Now, glutathione, what's important about it is it fights oxidative stress in the cell. So without NADPH, hence a G6PD deficiency patient, glutathione is not generated, and the cell is more vulnerable to oxidative stress because we don't have our glutathione around anymore. And therefore, what happens? We get hemolysis. We start hemolyzing our cells. Now, 10%, there's a 10% incidence in African Americans and persons of Mediterranean extent. Exposure to oxidative stress can be acute, self-limited intravascular hemolysis, hemoglobinuria, where you see dark urine, hemoglobinemia, and jaundice. Now, let's talk about some oxidative stressors. Some oxidative stressors include infection, primaquine, antimalarial drugs, sulfas, that's a big one, sulfur drugs, nitros, and fava beans. They love to go for this one, so make sure you pay attention to that. If you ever see anything about fava beans, start thinking right away for G6PDH, or G6PD deficiency, sorry. So, we also see two things in these, and that is, let's switch colors here. You see something called Heinz bodies. Now, a Heinz body is an intracytoplasmic aggregate of precipitated hemoglobin. But you also see something called a bite cell. Now, bite cells is a splenic macrophage that will attempt to phagocytize the Heinz bodies. Therefore, it leads to formations of bite cells. So that is G6PD for you in a nutshell. So now let's talk about pyruvate kinase deficiency, which is not nearly as in-depth, but it is a chronic lack of ATP, which leads to membrane damage, which leads to extravascular hemolysis. Pyruvate kinase is an ATP-producing enzyme in the glycolytic pathway. Since RBCs can only produce ATP through glycolysis, this deficiency severely affects the ability of RBCs to produce energy. So a decreased ATP production in the RBC causes an altered membrane integrity. Therefore, what do we get? We get hemolysis. Hemolysis. And that's what pyruvate kinase deficiency, that's the problem with it. So that is the enzyme deficiencies of the normochromic anemias. Now let's talk about the hemolytic anemias. Well, you have the warm autoimmune hemolytic anemia, which gives you a positive direct Coombs test. Now, this is the most common immune hemolytic anemia, and that is warm autoimmune hemolytic anemia is the most common immune hemolytic anemia. You have IgG autoantibodies, autoantibodies most active at 37 degrees Celsius. That's why they call it hence warm autoimmune hemolytic anemia. It's associated with underlying diseases. Underlying diseases such as SLE, Hodgkin's, non-Hodgkin's lymphoma, chronic lymphocytic leukemia, etc., things like that. All right, it's associated with some drugs, specifically alpha-methyl-dopa, which stimulates the production of autoantibodies against Rh antigens. It commonly results in extravascular hemolysis. Extravascular hemolysis by splenic macrophages, so you're going to see splenomegaly. So what about the cold agglutinin disease? And so, as I was saying, the warm autoimmune hemolytic anemia, which gives you a direct positive Coombs test, is the most common hemolytic anemia. Sorry if I said that twice, I just want to be clear about that. Most common hemolytic anemia is the warm autoimmune hemolytic anemia. So, it commonly resulted in what, by the way? Intra or extravascular hemolysis. That's right, extravascular hemolysis by splenic macrophages, and that's why you see splenomegaly. So you could see encapsulated organisms causing problems for these people. So what about the cold agglutinin disease? This is IgM antibodies. IgM antibodies, usually against one group antigen. It can be triggered by EBV, mycoplasma, and mononucleosis. Mononucleosis. So, what about hemolytic disease of the newborn? Well, hemolytic disease of the newborn is erythroblastosis fetalis. It can be prevented by administering something called RhoGAM. RhoGAM. An anti-Rh IgG to an Rh negative mother after 28 weeks of gestation and again within 72 hours of birth. Now, the hemoglobinemia from hemolysis can cause kernicterus. Kernicterus, where is deposition of lipid-soluble bilirubin in the basal ganglia, so you get permanent neurological damage. There's nothing you can do. So what do we know about hereditary spherocytosis? Well, it's autosomal dominant, and it can occur if one of several membrane skeleton proteins is defective, specifically spectrin, Spectrin and ankyrin. Spectrin and ankyrin are the most commonly affected ones, and also protein 4.1. I know I used to hate memorizing this stuff. And band 3. Alright, so spectrin, ankyrin, protein 4.1, and band 3, all with hereditary spherocytosis. Now, without the structural proteins, the RBCs assume a spherical shape, so they cannot move easily through the spleen, so therefore you get an extravascular hemolysis by splenic macrophages. The pathognomonic lab is an increased MCHC, or mean corpuscular hemoglobin concentration. How do we diagnose hereditary spherocytosis? We diagnose it with something called the osmotic fragility test. Osmotic fragility test. Because of membrane defects, spherocyte RBCs will lyse more easily in a hypotonic saline. Now, the treatment for this is a splenectomy. It will cure the hemolytic anemia, but not the underlying RBC defect. So what about hereditary elliptitosis? A lot of people overlook this guy. Patients are always anemic. Patients are always anemic. Hereditary elliptocytosis. Patients are always anemic. And paroxysmal nocturnal hemoglobinuria. This is a spontaneous de novo somatic mutation of the GPI anchor protein for CD55 and CD59. Those are both attachment proteins. Now the corresponding gene is PIGA, and that stands for phosphatidylinositol-glycan class A on the X chromosome. So what CD55 and CD59 do is they inactivate complement. See the problem? So the GPI anchor deficiency leads to complement-mediated hemolysis. So with complement-mediated hemolysis, the GPI anchor deficiency is what leads to that. So patients occasionally or paroxysmally wake up with hemoglobinuria, usually in the night, right? Because that's when you become acidic and that's when you would have blood in your urine. So signs and symptoms include anemia, thrombosis, pancytopenia, and a hypercoagulable state. Because how do every paroxysmal nocturnal hemoglobinuria patients, they die from some type of stroke or some type of hypercoagulable state. So just know that about them. All right. So sickle cell disease. Well, sickle cell anemia or sickle cell disease is it's a definition of a hemoglobinopathy. It's a hemoglobin structural abnormality that causes hemolytic anemia. So that's the big picture. It causes hemolytic anemia. Causes hemolytic anemia. Now, hemoglobin S is the beta globin gene point mutation that substitutes valine for glutamic acid at codon 6. Sickle cell disease is homozygous, and it's also, you see severe hemolytic anemia and hemoglobin S. The sickle shape is due to spontaneous polymerization of hemoglobin S in deoxygenated states. The painful crisis is usually during dehydration, infection, temperature extremes, or sudden decreases in ambient O2 tension like high altitudes. You can have an autosplenectomy, which is increased risk of disseminated infections from encapsulated bacteria like H. influenza, meningococcus, salmonella, pneumococcus. You can also see viral infections such as parvovirus B19, which causes an aplastic crisis like we've talked about, with a major decrease in hemoglobin concentration. Patients with sickle cell are at an increased risk for renal papillary necrosis and salmonella osteolitis. That is going to be a question, I promise you. Splenic sequestration occurs in children who have normal, intact spleens. Entrapment of sickle-celled RBCs leads to a rapid enlargement of the spleen. This can lead to hypovolemia and shock and can be fatal. So, sickle cell patients may undergo extramedullary hematopoiesis, just like in beta thalassemia, and it can often see the same characteristic crew-cut skull x-ray that occurs in other conditions with extramedullary hematopoiesis, like I just said, beta thalassemia. So the treatment of sickle cell includes something called hydroxyurea. Hydroxyurea causes an increase in hemoglobin F synthesis, and it's used in severe cases. So the sickle cell trait is heterozygous hemoglobin S, and it's largely asymptomatic. Now, you can have something called hemoglobin C disease. Hemoglobin C disease, which is the same codon is mutated as in hemoglobin S, the beta chain of codon 6, except lysine and not valine is substituted for glutamic acid. And hemoglobin C homozygotes have a milder disease than hemoglobin S homozygotes. And that's pretty much what you need to know about sickle cell anemia that you will be tested on. So let's do an overview of anemia. The most important thing you look at right away is the MCV, the mean corpuscular volume. It's one of the best labs used for categorizing anemias. It is the best lab in my opinion. If it's below 80, it's microcytic. If it's above 100, it's macrocytic. If it's 80 to 100, it's normocytic. It's literally that simple. Very easy, very quick. So microcytic anemias were your thalassemias, your anemia of chronic disease, your lead poisoning, your iron deficiency. So thalassemias will show target cells and basophilic stifling. Now, sideroblastic anemia is associated with a myelodysplastic syndrome known as or basically that's a pre-leukemia, as well as chronic alcoholism and lead poisoning. Anemia of chronic disease commonly presents as a microcytic anemia. The best way to differentiate a microcytic anemia is by the serum ferritin levels, okay? The best way to differentiate a microcytic anemia is by the serum ferritin levels. That's for your microcytic anemias. Thalassemias will have a normal iron study because there is no deficiency of iron in thalassemias. And anemia of chronic disease will have an increased ferritin, a decreased saturation of transferrin, and a decreased serum iron. Iron deficiency anemia, that one is going to have a decreased ferritin because of deficient iron stores. But TIBC can also be used to differentiate iron deficiency anemia from anemia of chronic disease. Recall that TIBC is inversely proportional to the body's iron stores. So if TIBC is up, the iron is down. So when the iron stores are low as an iron deficiency, TIBC would be, you got it, increased. So what would your TIBC levels look like if your iron stores are adequate, as in like anemia of chronic disease? They would be decreased. Very good. Let's talk about the macrocytic anemias or the megaloblastic anemias. This is your B12 and folate deficiencies. Now, B12 has associated neurological defects, and folate deficiency has no neurological defects. In In both B12 and folate deficiency, you look for hypersegmented neutrophils. Other lab findings include a hyperhomocystenemia seen in both B12 and folate, hyperhomocystenemia, but only the methylmalonyl acidemia is seen in B12 deficiency. The two drugs that can induce this is AZT and phenytoin. And that is macrocytic anemias for you. So normocytic anemias, this is pretty much everything else, but a few notable examples. Anemia of chronic disease can cause a normocytic anemia. Leukemias, aplastic anemia, enzyme defects like G6PD, and hemoglobinopathies such as hemoglobin C, sickle cell, where you look for target cells. All right, so what about haptoglobin? Haptoglobin binds to free serum hemoglobin. Okay? So a decreased serum haptoglobin suggests increased intravascular hemolysis. So if haptoglobin decreased, that means you have seen intravascular hemolysis. Now, if you have a decrease, that would mean more hemoglobin released into the serum. Now, if you have a decreased haptoglobin, it can suggest liver disease. Liver disease. The liver cannot produce normal levels of haptoglobin, so that could be another reason why. Now let's talk about lactate dehydrogenase. Lactate dehydrogenase is very abundant in RBCs. It's very abundant in RBCs. So increased serum LDH suggests hemolysis. So an increased serum LDH, lactate dehydrogenase, suggests hemolysis, but this is not specific. You need more evidence for hemolysis to make the diagnosis. So what about the direct Coombs test? Well, the direct Coombs test, aka the direct antiglobin test, is used to detect antibodies that are bound directly to the surface of RBCs. Bound directly to the surface of RBCs. And the anti-hemoglobin can also cause agglutination, thus constituting a positive test. A positive direct Coombs test suggests an autoimmune hemolysis. Now, an indirect Coombs test detects free-floating antibodies in serum. Free-floating antibodies in serum. So a serum sample is incubated with RBCs with known antigens. So if you see RBC agglutination, that's a positive indirect Coombs test. So it's used to cross-match blood for transfusions and in antenatal antibody screening, such as in anti-RH antibodies against the RH-positive fetus, etc. So that's what those are about. And that's an overview of anemias. So now let's talk about polycythemia. Polycythemia is an increased hematocrit, hemoglobin, and RBC count. That's what it is. Now, what is an absolute? So an absolute polycythemia is an increase in bone marrow production. of RBCs. Okay? An appropriate polycythemia is an RBC count that increases in response to chronic hypoxia. Okay? So if you get a hypoxic stimuli, you get a decreased O2 saturation due to like a high altitude. Primary lung disease, you can get cyanosis due to heart disease or coronary carbon monoxide exposure. So you want to see an increased RBC count, an RBC mass, and an EPO. Let's write that in there. You want to see increased RBC count, RBC mass, and an increased EPO with an appropriate polycythemia. Now the plasma volume is going to remain normal. What about an inappropriate polycythemia? This is when the RBC count increases without hypoxic stimulus. The RBC count increases without a hypoxic stimulus. So if you have no hypoxic stimuli, that means you're going to have a normal O2 saturation. So therefore, ectopic EPO production should increase the RBC production, which should increase the RBC mass and RBC count. But the normal O2 saturation distinguishes inappropriate from appropriate polycythemia. So it is all about the O2 saturation. It is all about the O2 saturation to separate appropriate and inappropriate polycythemia. Now the plasma volume can be normal or increased. Now in an inappropriate absolute polycythemia from ectopic EPO production, what do you see? You see a normal plasma volume. Well, let me say that again. An inappropriate absolute polycythemia from ectopic EPO production leads to a normal plasma volume. But if you have an inappropriate absolute polycythemia from, say, polycythemia rubra, that's going to lead to an increased plasma volume. Alright, so now let's talk about a relative polycythemia. Now, a relative polycythemia is due to decreased plasma volume. Decreased plasma volume, which causes an increased hematocrit, hemoglobin, RBC count, and relative total plasma volume. Alright, so due to volume depletion can be like sweating, diarrhea, a burn victim, etc. That's going to give you a relative polycythemia. How do you correct it? Well, you replace the fluids for step 2. That's what they're going to ask you. How do you correct this, or what's your next step in management? Is you replace the fluid. You add whatever was lost. Usually during sweating, it's a hyposomatic fluid loss, so you replace it with a hypotonic salt solution like Gatorade or Powerade. So the big tip-offs here with relative polycythemia, what is different about him? what will his plasma volume be? It'll be down. What about a appropriate and inappropriate polycythemia? What would their plasma volume be? Normal. So when would my plasma volume be up? In polycythemia rubra. Very good. Polycythemia rubra is due to acquired mutations to the myeloid stem cells, by the way. So, when is the one time of these four relative, appropriate, inappropriate, and polycythemia rubra? When would the EPO be decreased? Polycythemia rubra. When would it be normal in a relative polycythemia? And when would it be increased? In both appropriate and inappropriate polycythemias. So, what's the only difference between an appropriate and an inappropriate polycythemia? The O2 saturation. Very good. All right. And that is polycythemia for you.